Hey guys, what's up? It's Shay. I'm a flight nurse and a paramedic, and today I'm going to answer a frequently asked question, and it is, what type of calls do we do? But I'm really going to dive into it today, and you're going to learn a little bit about the company I fly for because we do some really neat stuff. So this question was originally brought up to me by somebody who flies or works on the ground in Canada. I'm not sure which one, but it did get me thinking that US configurations probably are different than other places in the world. So the most common configuration that you see in the US is a flight nurse and a flight paramedic. And the reason that we do that is because the paramedic comes with really good pre-hospital experience, good airway experience, and the nurse comes with really good in-hospital experience, that hemodynamic stabilization that comes from the ER and the ICU, pressor and pharmacological management, invasive devices, invasive monitoring. When you put those two together, usually you should have really good experience that can troubleshoot whatever patient you get. So that's the most common configuration that you will see. You will see doctors that fly in some places. You will see NPs that fly. But in general, across most flight services, we fly a nurse and a medic. How this branches out. There are two main types of calls we do, and we call it a scene call or an interfacility transfer. Now I'm going to refer down to my notes because I'm going to take from the comment that our friend from Canada put. Where they're from, which is Ontario, it says, our ambulance service runs three types of calls, and one is standard traumatic injury, car crashes, etc. So that's probably going to fall under what we call a scene call. Now, a scene call means that we are flying right to the scene of the emergency, but it could be medical or it could be trauma. Typically, it is trauma. That's going to be us landing on the highway for a car accident or a motorcycle accident. We do a lot of farming accidents. Anything where there's major trauma involved, we fly right to the scene of the accident. And in that case, my partner and I decide what hospital is most appropriate to take that patient to. Now, conversely, we can do what's called an interfacility, and that means hospital to hospital. So a patient goes to one hospital and they get diagnosed with an emergency that hospital does not have the resource to treat. And it's time sensitive, so they need to fly to a bigger hospital that has the resource they need. And what we call an IFT, I'm pretty sure is what this person is calling an IFF in Canada. So that's hospital to hospital. That means that the doctor has seen the patient in the ER and they have done a doc to doc and they have accepting at a predetermined hospital, and that's where we're taking that patient when we go to pick them up. They also mentioned long range transfers from the bush. I'm sure that there are places in the US that are very rural. We might call it that way, but I've never heard anybody refer to it like that in the US. But yeah, helicopters are used commonly for rural areas because the patient needs to get to a big facility fast, and whatever local hospital is in this rural area probably doesn't have the resource they need. This person says often military medics parachute in to provide care. Now, there are a few services I know in the US that do have hoisting programs. Sometimes it ends up being like the state police that do it, or if that is a resource that's not available, sometimes they'll call in the National Guard and they will hoist. Predetermined rescue setups within different fire departments and first responders sometimes have those capabilities. For us personally, we do not have a hoist system. So we had a patient that had fallen somewhere that needed that. We might call the state police, or in another state, they would call a resource that does have hoisting. Then they talk about long range IFFs for complex cases, especially peds and neonate. So your IFF is like our IFT, not always long range though. The helicopter typically services like 100 miles or less, because once we get past 100 miles, we're not really benefiting them with the time aspect, and it's likely that there is another helicopter base that's going to be closer to that patient after 100 miles than ours would be. For example, we have multiple bases within our state, and there are also other flight services within our state that could be closer. Usually when the call comes in, it just goes to whatever the closest helicopter base is to the emergency. So I'm going to break down scenes a little bit more. Ours get a little interesting because we do a lot of ECMO at our program. So while we do the normal traumatic scene calls and medical emergency calls, we also do a lot of cardiac arrest. And there is a sub breakdown within how ECMO requests for cardiac arrest come in. There are technically 4 types of ECMO calls that we do. 3 of them involve going to the scene, and 1 of them is just your typical hospital to hospital. The patient's already cannulated. So this is ever changing because as this program evolves and develops and we get more buy-in from other EMS systems and other hospitals, the criteria changes. And the more that that there are studies done, the more that we develop the program as well. So there is what we call an eCPR flight. This means that the patient has gone into witness cardiac arrest, and they have requested that we come fly this patient while they're in cardiac arrest to the University of Minnesota or the closest cannulating site to a mobile clinician and physician who can cannulate. And so what that looks like is we fly to the scene. The patient is already getting compressions by a Lucas, and hopefully EMS has already begun care. And we just swap our Lucas out and scoop that patient up, and we do all the care in the helicopter because we're trying to get him to that doctor under an hour. So that's the first type of scene ECMO that we do. The second type is where we pick up a doctor and a ECMO specialist, and we fly them to a hospital that we have an agreement with, and we use their hospital as a cannulation site. So EMS grabs the patient in cardiac arrest, we grab the doctor, and then we converge and we meet at a hospital, and they'll use their ER to cannulate the patient. Cannulating the patient gets good oxygen-rich blood flowing and buys them time to get to a cath lab to see if they can fix whatever has gone wrong with their heart. Gives them time to figure out what's going wrong with them while we know that their brain is getting oxygen-rich blood. The third type of scene call is called a rule scene ECMO activation, and that's when we pick up the doctor and the ECMO specialist. We take one lifeline clinician, such as myself, and the pilot, and once we pick them up, we fly right to the scene of the cardiac arrest, and the doctor and all of us will cannulate the patient right there at the scene of the cardiac arrest. That's probably our newest program, and there are some other ECMO stuff going on outside of flight where they can take their ambulance or ECMO 99, and if it's closer to the metro, they can use that resource. Flight is utilized for rule because we can get further out than a lot of times we can respond to by vehicle because we're trying to get to these patients in under an hour. So while we do normal scenes, we also do a lot of ECMO stuff as well that also qualifies as a scene flight as well, technically. And that's a really cool thing that we're pioneering, and we're really wanting it to catch on in the country because it's such an amazing resource. And then we have just what we call regular ECMO, where a hospital has cannulated the patient, but maybe they don't have the resources to keep them or the beds to keep them. And so we will go get that patient who already is on ECMO, and we will fly them to the University of Minnesota or somewhere else in the metro that can handle an ECMO patient, has resources for them. Now we can take the ECMO patient in our airplane or our helicopter, depending on how many extra things the patient has, because this is space sensitive, right? So if they have a balloon pump, the ECMO pump, they have multiple chest tubes, it might be more practical to take them in the fixed wing. If they don't have as many things and they can fit safely in the helicopter and distance it's practical geographically, then sometimes we will take ECMO in the helicopter as well. So a lot of moving parts, a lot of factors that go into determining what aircraft you get and when. Now this question talked a little bit about pediatrics and neonates. So a true neonate, somebody who's just been born and they know that they need to go to a children's hospital or a children or pediatric specialty hospital in the metro, we'll pick up our NICU team. They have the beautiful isolate. They have all the resources. A lot of times it's a nurse practitioner and an RT that we take with us plus one of us. And we'll go get the neonate and they'll do all their magic and we'll take them and basically be their escort back to the hospital. However, we at our flight program are trained in neonate to adult because we do scene calls and we can't predict the age of somebody on scene. So we need to be able to go to scene and still be able to treat a neonate. So we all have our neonatal certifications and all of our equipment goes down to itty bitty baby size as well. We do not have an isolate though, so it's obviously not the best case scenario, but compared to some other situations and transports that maybe aren't available, sometimes we are the next best thing. But outside of a neonate, we do all the babies, we do all the kids. So we all have to be versed in babies, children, and adults at this flight company, and really any flight company that takes scenes, because you cannot predict the age of the patient that you are going to have to fly. This person also asked how much of our call volume is which, and I would say we do a really good mix here. At our base, we do a lot of scene and a lot of interfacility. Some bases tend to do a lot of transfers if they're really far away from the hospital, and some are very scene heavy if there's not like an ALS service that can handle a lot in that area. But I would say that most flight companies do a mix of scene and interfacility. They also ask, how often are we first on scene? Not often. I've had maybe less than a handful of times in my career that I've beat an ambulance to a scene and it was so bad that we needed to initiate care. But usually it is the ground paramedic who is calling us, which means that they have made it on scene and they initiate contact. The other thing is we do need somebody on the ground to set up an LZ for us to be able to land safely. So we're never ever first on scene because even fire or EMS would need to be there to make sure that we have a safe landing zone, make sure nobody's going to drive into our LZ. If they need to shut down a road, they can do that for us. So typically we are a second responder. Our base is a metro base, which is not common. Most helicopter bases are more rural, and within our company, we do have very rural located EMS bases, but ours is pretty metro. So we pick up a lot of scenes around here on the highway and accidents, and our flight times tend to be pretty short. Like oftentimes we get into the air and the pilot's like, hey, we're 12 minutes out. And we're just doing everything we can within that 12 minutes. And sometimes we don't even get to everything because of how short our flight times are. There are bases, though, at the company I worked at last, where our flight time was 45 minutes a lot of times. So we had a lot of time to treat the patient before we got to the trauma center. Now I think it's a good time to talk about just what criteria would make you activate flight in general. So this list could go on pretty much like for a really long time. I'll just give you some common examples to help paint a bigger picture. So flight can be activated by police, by fire, or by ground EMS, by the paramedic on scene. Sometimes there's auto activation criteria that when a dispatcher takes a 911 call, it just automatically launches an aircraft if it sounds like it's going to be bad. And then when the paramedic on the ground gets there, they can choose to cancel as if it's not as severe as they thought it was going to be. So patients needing blood products, we carry blood. A lot of ground services don't carry blood. In fact, we carry whole blood and liquid plasma. Any type of multi-system trauma where that patient really needs to get to surgery fast. Any emergency that they need a specialty or a surgeon and it's time sensitive, that's indication to call a helicopter. A lot of ground services don't have paralytics or RSI, so they will call us because we have paralytics, or if they think it's going to be a bad airway in general and they want some advanced airway experience on the ambulance to help, they may call us as well. Bridges us to respiratory emergencies. Any type of like COPD or asthma exacerbations, pulmonary embolism, all types of respiratory emergencies could warrant a helicopter ride. Severe burns, crush injuries, any type of long bone fracture. So anywhere that we could have a lot of bleeding hiding in a compartment, somebody that's going to need an ortho specialist and maybe a trauma surgeon, again, is going to get that activation. Somebody that has a high shock index and they're hypotensive, it's a good indication that they are bleeding in hypovolemic shock. That's an indication. Really, we could be called for any type of shock, be it obstructive, septic, hypovolemic, anything like that. Somebody having a stroke, whether it's a head bleed or whether you think it's ischemic, that's somebody who probably needs neurology fast, maybe needs to get to TPA, maybe needs to get to IR. That's somebody that we would fly. Anything that has an increased ICP that could need an emergent intervention, that's definitely criteria to fly. Ocular emergencies, just anybody who's like interfacility, anybody who's on like multiple drips, invasive monitoring or invasive devices, that's definitely indications to call as like balloon pumps or Impellas, or they have a swan in. Also OB emergencies. Obviously, we really try not to deliver babies in the aircraft because it is not the best space. But if mom's life is like it's life or limb to get mom to a facility that can handle what is going on with her emergency, we'll absolutely fly them. And obviously we want to take good care of mom and the baby, so we'll do OB emergencies as well. Basically, there's a lot of nuance in how we train because there are so many different emergencies that we could have to respond to. And so we just carry the most amount of equipment and the smallest amount of space that we can to be able to get people where they need to go fast and make sure that they can get good care. One of the main things that we give patients is time. Is a fast ride to get to definitive care. But that's why we do have an advanced scope to manage these patients so that we can initiate resuscitation if they need an invasive procedure right now to save their life. Hopefully we can do it. And hopefully we drop them off a little bit better than we picked them up. And then I'll just speak on the fixed wing a little bit. So that's also primarily an interfacility transfer operation because of the distance. It's not always going to be the best use for time, but sometimes really sick patients need to get to specialty hospitals. And so that would be like our long range transports. Those go on the fixed wing over a certain amount of miles. It'll automatically trigger the fixed wing. It's just less practical to get in a helicopter and have to stop and fuel multiple times and take that resource out of the main service area where it could be used for scene response than it would be just to send our airplanes. So we do a lot of invasive devices, a lot of ECMO, and a lot of people needing to go to specialty facilities on our airplane. As always, I appreciate the question and I thought it sparked a really neat video. If you're just curious on what the heck actually goes into an aircraft that's deemed a medical emergency. So I appreciate you guys listening. Again, don't forget to like and subscribe.
Hey, yeah, let's go. Yeah, let's go.